Hello everyone, myself Dr. Sheena. So today I'll be dealing with the topic endodontic surgery. This is yet another important topic when we prepare for the NEET MDS PG examination. So what is endodontic surgery? Endodontic surgery is a removal of tissue other than all the tissues in the pulpal area or the root canal is called as endodontic surgery. So what is the classification of endodontic surgery? Endodontic surgery include incision and drainage. In patients where we have a swelling, we need to put our incision so that the drainage of pus take place. Cortical trephination is also where we will apply a small window on the cortical plate which actually relieve the pressure and decompression procedures. Periradicular surgery include in certain cases whereas there is large lesion in the periapical area. In order to remove the granulation tissue, surgery is done. The granulation tissue is removed by the curettage method where it is actually scraped off. And sometimes the periapical area of the root is also involved. In that, we have to do a root resection procedure, that is the cutting of the root is done. And at the end, we need to do a root end preparation, that is another periradicular surgical procedure. Last, it is root and filling, that cavity has to be filled. So these are the classification of periradicular surgery. Next is corrective surgery. When we actually do a root canal, sometimes this might be the apical foramen. So due to improper treatment being done, it might actually lead to a near transportation area. So this is a opening newly created, so that need to be actually closed, or there might be perforations in the middle third and apical third of the tooth where it is really difficult to treat. In those cases, we'll need a endodontic surgery. So it is used in perforation repair, periodontal management, especially in tooth where the infection is involving the percussion area and periapical area. Sometimes we might actually cut the tooth through to the center. This is called as root resection and also tooth resection. And next is intentional replantation, where the tooth is extracted from one area and it is placed to the other area. Now, talking about the contraindications of endodontic surgery, there are absolute contraindications like the leukemia, neutropenia, uncontrolled diabetes, cardiac surgery, and debilitated patients. In these patients, it is absolute contraindicated. Now, the relative contraindications include anticoagulant therapy, where we can actually stop the anticoagulant drugs and also we can actually do the endodontic procedure. That is why it comes under relative contraindication. And patient undergoing radiation, sometimes the patient might be under drug of bisphosphonate for treating of osteoporosis, multiple myeloma, etc. In those patients, if we do a surgery and the patient is going surgery, there's a chance of development of bisphosphonate related osteonecrosis of jaw. So those are relative contraindications. And next is like pregnancy first trimester, it is contraindicated. The anatomic consideration, especially when we do the surgery of the maxillary upper tooth, it is very important to check and safeguard certain anatomic areas like the nasal floor, maxillary sinus. And there is neurovascular bundles that is present on the upper part, and periodontal consideration should be done. The first step, that is incision and drainage. As you know, incision and drainage, there will be a swelling that is actually present, and the most fluctuant area we'll use a scalpel blade which is pointed, such as the 11 or 12 pointed blade is actually used to make that incision rather than the rounded 15 blade. So we use 11 or 12 blade. The incision should be in a horizontal and placed at the most dependent base of the fluctuant area. It should be placed like a horizontal base, not vertically, and that horizontal releases large amount of exudate outwards. Next is cortical trephination. Cortical trephination is a procedure, as you can see in this image. Cortical trephination is a method where a small window is actually created on the cortical bone. As you can see in this image, a small window is created in the cortical bone so that we can have an access towards a periapical area. So cortical trephination, as the name suggests, a perforation is done on the cortical bone so that there is release of the pressure which is accumulated on the because of the pressure that is by the exudate that is seen in the periapical area. Right, it is just a window or a perforation done on the cortical plate where it is indicated. Moderate to severe pain with no intraoral or extraoral swelling, where the drainage is required. The patient might have severe pain, but it is not even having swelling. So in that cases, we have to make a perforation or window in the cortical plate. So what is the method? Cortical trephination involved the incision through the mucoperiosteal tissue and perforating. First of all, mucoperiosteal tissue incision is done. After that, the cortical plate is actually perforated, right? So you can see in this image, this is cortical perforation. The site most recommended is at or near the root apex. Very important. It is at or near the root apex. So the pressure is actually relieved and the pus comes out. Cortical trephination should always be initiated in the buccal plate, not on the lingual plate. So these are the important things that you have to read on the cortical trephination portion. Next question, draining abscess by cutting a window in the bone is, as I said, it is a window or a perforation done on the bone. It is called as what? It is trephination or cortical trephination. There are some principles that has to be followed when we do a flap designing. First step in endodontic surgery is actually the flap design and also flap reflection. So avoid horizontal and severely angulated vertical incision. The horizontal and severely angulated incision should be avoided because there is a chance of tearing and it is really difficult for approaching this material here. Avoid incision over radicular eminence. There is an eminence over here. It should be actually avoided. Incision should be placed and flap repositioned over solid bone. Where there is bone, we have to reposition on that particular area. Avoid incision in major muscle attachment because there is chance of a tear of actually muscles, etc. Tissue retractors should rest on solid bone. You can see this. Once we actually reflect the flap, the retractor should actually be seated on a solid bone. Extent of the horizontal incision should be adequate to provide visualization and proper access. So once we make a horizontal incision, it should be in such a manner we should reflect it and we can see that area properly. Always the junction of horizontal and vertical incision should either include or exclude the involved interdental papilla. So this is the interdental papilla. We can either include or exclude the interdental papilla. The flap should include the complete mucoperiosteum. So in most of the cases, full thickness flap is most recommended. So which is true about mucogingival flap design? Flap should be wider at the base. Flap should be narrow at the base. From that itself, we got the answer. Always the flap should have a wider base. So it won't get teared or it is easy for the approximation and for the suturing and all. Classification of surgical flaps. The full mucoperiosteal flap, which is the most recommended flap, and also the limited mucoperiosteal flap are there. So triangular flap, as you can see, it consists of a single vertical releasing incision. That is an important point. Only a single vertical releasing incision is there. And rectangle means it consists of a single and again two vertical incisions are there. Trapezoidal means it is similar to that of triangle, but it will slightly be angulated. So that is trapezoidal incision. And horizontal incision is like non-releasing incision, right? Now, first is triangular flap, where it is indicated. especially in the maxillary incisors and the posterior teeth. Only recommended flap for mandibular premolar. So in the case of premolar, posteriors, we actually recommend the horizontal triangular flap. Next, mid-root perforation repair also. In mid-root area, if there is perforation repair, we can actually apply this flap design. So what is advantage is like we know that approximation is very easy. So there will be, because only one part of the flap is being actually tiered and reflected. So there is easy approximation and good healing will be there. But the one problem is like we know that only one part is actually incised. So what is the problem is like it is difficult for the access. We will have a limited surgical access and difficult to expose the apices of the root is there. Rectangular flap, as I've explained earlier, it have two vertical flaps. So it is used in mandibular anteriors, multiple teeth with long root where we can reflect the entire flap, lateral root repairs, large lesions, etc. Posterior, because it is contraindicated because it's difficult for actually the suturing and approximation. Right. Again, advantage, we have a very good access. Difficulty is like reapproximation is difficult because both the ends have been actually reflected and difficult to stabilize. Next is trapezoidal flap, similar to that of rectangular flap. Only difference is like there is a slight obtuse angled this thing. And also they have a broad based flap where it is indicated. Cervical resorption defect. When there is actually a resorption defect in the cervical area, in those cases, we'll be actually doing a trapezoidal flap. Next is endoperio lesion is there. When the connection area has to be seen, we'll be doing this. Hemisection and root amputation also, trapezoidal flap will be taken. So what is the advantage? Since it is obtuse angled, it is easy for its reposition. The disadvantage is like difficult to retract and sometimes it might have a limited access. Limited mucoperiosteal flap, that is a submarginal or sublunar flap. As you can see, it is like a half moon structure, that is sublunar flap. It is one of the most aesthetic incision where it can be done in the aesthetic crown area. Trephination cases where we have to put a hole on the cortical plane, just a small flap can be actually reflected like this, the semilunar flap can, and there we can actually put the bar mark. Advantage is like very easy incision, reflection time is not there, and there's chance of actually easy integrity of the gingival margin is attached and bone is not touched. These are actually the advantage. What is the difficulty? We know that it is really difficult for the accessibility, and once it might affect the wound healing, scarring, etc. Next is submarginal scalloped rectangular flap. This is actually, it is not a full thickness flap. Okay. Lubic ostomic flap is there. So what is like, it is 2 to 3 mm away from the gingival margin. There will be actually, it is similar to that of the rectangular flap, but it does not actually involve the gingival the papilla, dental papilla. This is the most common for endodontic surgery. This is one of the most common for endodontic surgery, and it have a wide band of attached gingiva. You can see here it have a wide band of attached gingiva over here. Advantage is like it does not involve the interdental margins and interdental gingiva, etc. The crustal bones are not exposed. Ease of incision and reflection. So disadvantage is like there is a chance of vertically oriented blood loss and collagen fibers may be cut off or severed. Right. So that was about flaps. Once flap is reflected, next we have to do a osseous entry. Now the flap is reflected here. Now we have to cut the bone. The cutting of the bone or the osseous entry is called as osteotomy. The osteotomy involved the removal of the cortical plate and the cancellous bone to have a direct access to the apical portion of the tooth. So what is the ideal adequate osteotomy? The ideal adequate osteotomy is 4 mm in meter. We can actually go to an 4 mm in meter, mm in diameter. So how will we cut the bone? There are certain hand pieces which is having a angulation of 45 degree. It is an impact air 45-degree handpiece, and burrs like Linderman's burr 6, 8 or round burr can be actually used for cutting the cancellous or the cortical bone or to do the osteotomy. Similarly, 57 Fisher burr is also used for an atraumatic osteotomy. Now, once we have actually reflected the tooth and we have cut the bone structure, now we have reached to the root end or the apical root. Now, we know that in the case of reinfection, what we do is apisectomy is done. Why apisectomy is done? Especially 3 mm of the root end is cut. Why 3 mm of the root end is cut via perpendicular resected? That is because this 3 mm consists of large amount of accessory canals and lateral canals which can harbor large amount of microorganisms which might be the reason for the reinfection cases. So in these cases also we can actually use impact air 45-degree handpiece can be used. So this is the method. Flap reflected, bone osteotomy is done. You can see the resection of the root have done. We have actually cut about 3 mm of the root might be like this. We have cut the 3 mm root. Next is what we have to do is like cavity cutting is done. You can see the root end cavity preparation is done. See, root end preparation is done. That is to actually seal the particular area to avoid the microorganism proliferation, etc. Always the cutting bevel should be closer to 0 degree. Very important. Why so? If it is angulated, there is chance of the dentinal tubule to expose outward, and it might be a pathway through which the microorganism can enter into the tooth, again causing reinfection. The depth of 3 mm is ideal for retro preparation. Very important. So how will we do a root and preparation? In early times or traditional times, we used to actually do after cutting, it will be like this. After cutting, we'll be doing a burr. The problem with burr is like it won't be actually, the root surface is very small. So when we use a burr, large amount of tooth is being removed. In order to prevent that, we started using ultrasonic tips. As you can see in this image, it is not like a burr. The surface area is very small. So we can, another thing is like this is having angulations. The burr is like this. So it will have a single area of involvement, so we won't able to see. Even since this is angulated, we can have an access, the material won't obscure our view also. That is why nowadays ultrasonic retro tips are used for retrograde preparation, and one example is KISS ultrasonic tips. Now, as I said, we have cut that surface. Now the root is like this. We have made a cavity preparation like this, and we need to fill that. Early times we used amalgam. The problem, even though amalgam was dimensionally stable and all, the problem was like, there is chance of discoloration of the tissue called as amalgam tattoo, and another is there is corrosion products, safety issues, etc. So nowadays amalgam is not used. Instead, we started using MTA, that is mineral trioxide aggregate. So this is the most appropriate and recommended cement for doing a retrograde filling. And its composition is tricalcium silicate. This is very important. Tricalcium silicate is actually the material that is seen in mineral trioxide aggregate. So talking about mineral trioxide aggregate, in most of the cases we use nowadays MTA in a lot of cases like retrograde filling, perforation repair, pulp capping, indirect pulp capping, direct pulp capping, everything MTA is used. Why MTA? MTA consists of tricalcium silicate, tricalcium aluminate, tetracalcium aluminoferrate is there. MTA is of two type actually, white MTA is there, grey MTA is there. Based on this ferrite presence, iron presence is there, it is grey MTA. Iron is not there, that is white MTA. And bismuth oxide is there for its radio opacity so that it can viewed in the radiograph. MTA is biocompatible and hydrophilic in nature. That is the important property of MTA. Once we mix MTA, and you know that all the surgery is done in a periodontal space. There is blood, secretions, etc. So we need a material that is hydrophilic, that loves water, that does not, whose setting does not get affected by the water that is present. That is MTA, because MTA require the presence of moisture for its setting. Thus, it can provide an excellent sealing property even though if it get contaminated with blood. It is the only material that have the potential to regenerate the periodontal apparatus, where new cementum is formed directly on the MTA. So the two important disadvantage of MTA is like it's really difficult for the handling, and second, it have a longer setting time. So that may also affect our treatment protocol. So what are the methods how we place an MTA into that cavity? As you can see, Dongan MTA carriers are there, retrofill amalgam carriers are there, messing root canal gun is there, MAP system, leave MTA pellet forming blocks. Just memorize these things are actually used. You can see in the images, it is just like an amalgam carrier. Using this, we'll be actually holding the MTA and apply it into the cavity. So that was about the most important surgical part, whereas flap reflection, bone cutting osteotomy, root and cutting, root and cavity preparation, root and filling. Next procedure is root amputation procedure. Why we do our amputation? As you can see in these images, in most of the cases, sometimes there might be a single root. You can see this root is intact, but this root is not intact. There is large amount of bone loss here and also the near to the percussion area. So the prognosis of that root is bad. So rather than extracting the entire tooth, what we can do is like we can just to cut the unwanted root. Similarly is the second case. You can see this, there is loss of bone. They just cut off the unwanted weak diseased root. So that is called as radicectomy. Radicectomy is a method of removal of one or more root in the molars. What is bicuspidization? The other names are root separation and odontosection. You can see in this image, we will be actually bicuspidization through the cuspal area. We will be actually dividing the tooth into two parts. In cases where there is percussion infection, we can actually resect the tooth and make it into two separate tooth. Again, tooth resection is otherwise called as hemisection, bisection, or tooth sectioning. Again, in the posterior teeth, we will have a vertical cut. In this technique, the crown portion over the resected tooth is also cut off. That is the difference. Here, bicuspidization means both the cusp will be actually seen. While in the case of hemisection means we'll be cutting through the center and the crown portion of the involved root is also cut off. Right. Amputation, root amputation procedure is also the same name of eliminating the infected root. Radicectomy, again explained earlier, removal of root. Next is replacement surgery. What is replacement surgery? Deliberately, for certain treatment portion, we will be actually extracting the tooth and we will be returning to the tooth to the original socket. The act of deliberately removing a tooth and examining, diagnosis, endodontic manipulation, returning the tooth to its original socket. So why it is done is like sometimes the endodontic surgery might not be having a success. So what we do is like we'll be actually extracting it, doing the treatment, and once the surface is prepared in the root, it will be placed and secured by a splint, right? Now, once the flap is reflected, another important thing is sutures. Sutures are of two types, resorbable sutures and non-resorbable sutures. The silk, nylon, polyester, etc. are non-resorbable sutures, and resorbable sutures are those mostly extracted from the animal gut, etc. like chromic gut, collagen, polyglycolic acid, etc. And based on the filaments, it contains monofilament and multifilament is there. Monofilament is like collagen, gut, etc. Multifilamentous material like the resorbable type like polygalactin, PGA, silk, etc. Next is braided type is there, twisted is there. The size can range from 1 to 0, 1 to 9, right? So the advantage of actually silk is like it is made up of protein fibers, so they bond together with a biological glue that is produced by the silkworm, and it is mainly non-resorbable type and multi-filament and also braided technique. The advantage is like is limited to its ease of manipulation, and the disadvantage is like severe tissue reaction to the silk. Sometimes the tissue reaction might allergic reaction might take place. Gut is like collagen is the basic component of plain gut. Okay, collagen, which is mainly extracted from the sheep intestine. So it is treated with diluted formaldehyde to increase its strength, and it is also commonly used. Next is collagen. Collagen is actually made up of bovine tendon, and the collagen suture offer no advantage over the gut for endodontic surgery because the absorption rate and tissue response are almost similar. Polyglycolic acid is again it is an absorbable material. The rate of absorption is about 16 to 20 days, and handling character is similar to that of the silk. Polyglyctin is actually a copolymer of lactic acid and glycolic acid. That is why it is called as polyglyctin 910. It is again absorbable and braided type. So coming to the needles, needles are of various sizes, shapes, cross sections, etc. You can see it is round, oval, cutting, and also reverse cutting is there. The size of the needle compared to the regular and a circle, it consists of 3 by 8 of a circle is there, half of a circle is there, and 3 by 4th quarter of a circle is there. Right. So normally we use needles with round or oval cross section. It is mostly atraumatic in nature, especially in thin mucosa. And the disadvantage is like we need a lot of pressure to apply this rounded needles. Triangular needles are using thicker tissues, and the rate of tear is also less. Now, once the suturing and approximation, everything is done, what we do is like we have to give a surgical wound filling. Normally, petroleum gel is lactone gauze is used, iodoform gauze is used. Surgical dressing is actually given for a temporary protection so that the patient will be recalled after that. So these are actually the material which we place on the surgical site, and the patient will be left off. Now, what are the surgical complications? First of all, maxillary sinus infringements, that is, especially when we do the maxillary molar treatment, there is chance of affecting the maxillary sinus. Next is intraoral hematoma chances there, tissue trauma, trauma to the flap, foreign bodies at the surgical site, infection, paresthesia, and serious infection. So these are some of the surgical complications which can actually seen during the endodontic procedure. So paresthesia is mainly seen in the mandibular area, especially in the molar area, because there might be accidental perforation of the mandibular canal. Stitch abscess may develop due to local laceration of the tissue, and there is accumulation of the debris. So that can there were slight abscess might be actually seen. Ecchymosis is blood collection, skin discoloration because of the extravasation and breakdown of the blood adjacent to the surgical site. So that was all about surgery. Surgery is a very large topic and anything can be asked. The main thing that you need to study is like the root reduction, root end preparation materials, and the burrs and ultrasonic tips like kiss tips are actually used for the endodontic surgical procedure. So hope you had a nice class here. See you in the next class. Thank you.